Onc Live Insights is a video editorial program produced by Onc Live.
So the use of monoclonal antibodies as a maintenance is very interesting. That we been studied this for a long time, and we didn't have much of the data. There is a recent two publication that from Europe that explored this strategy using rituximab or ofatumumab after chemoimmunotherapy in this population of patients with chronic lymphocytic leukemia. There is no doubt that the comparison between maintenance with rituximab or ofatumumab versus observation alone confer a progression-free survival, which is significant. However, I think my comment will be that with incorporation of the BCR inhibitor, this progression-free survival is better achieved with targeted therapies such as ibrutinib or idelalisib.
I think ofatumumab is a reasonable treatment option as a CD20 antibody, as therapy both in the frontline setting as well as in the salvage setting. It clearly has activity. Are there any features of it to me that strike me as giving it a superior advantage over the others? I couldn't honestly say, yes, it has this feature, therefore it is a better CD20 antibody than the others. I think it's an active antibody. It's well tolerated. I've used quite a bit of it. I have had favorable experience using it as a maintenance, in fact, and that was actually before some of the maintenance data came out. It was based on the fact that I had participated in the pivotal trial and had experience using it, and have used it, including in patients with 17P, as a maintenance strategy to hold their disease in check and to extend out their progression-free survival. That's being confirmed now in a randomized trial that was recently presented, showing patients treated with chemoimmunotherapy in a response, either a complete remission or partial remission, randomly assigned to observation versus ofatumumab, and the patients who received ofatumumab as maintenance having a longer progression-free survival than those assigned to observation. So in terms of maintenance treatments, the small molecule inhibitors in and of themselves are maintenance therapy. So if we want to talk about the CD20 antibodies as a maintenance therapy, my experience and my opinion is that those patients who are most appropriate for a discussion for maintenance with a CD20 antibody are patients who've had a chemoimmunotherapy who still have measurable disease. If they're not in a good complete remission and they've had a chemoimmunotherapy regimen, for sure they're going to have a short progression-free survival. Their disease is going to be growing relatively soon. And I think it's those patients who are either in a partial remission, they still have measurable nodes, or they still have circulating leukemia cells. If we can get them on a maintenance strategy, we will likely be able to prolong their progression-free survival. The data supports that. Their progression-free survival, perhaps their overall survival, but the data don't yet support that. So it's patients who don't have a small molecule inhibitor as a treatment option, who have had chemoimmunotherapy, who are in partial remission, for sure. The complete responders, if they're minimal residual disease positive, then it's easier for me to justify going on a maintenance. If they're MRD negative in complete remission, then I would probably not consider a CD20 maintenance for those patients.
The rationale for maintenance therapy in CLL is that the 6-month duration of chemoimmunotherapy may result in a complete or partial remission, but we know that patients relapse, and they tend to relapse sooner if they have more residual disease, i.e. a partial remission compared to a complete remission. We also know that they relapse sooner if they're MRD positive versus MRD negative. So if one had a maintenance therapy that could improve the quality of response, there is a chance that that might then improve the progression-free survival. To date, prior to ASH 2014, we had not had much data to support use of any drug, actually, other than alemtuzumab in a maintenance setting. The data for alemtuzumab that existed were decent, but it was found to be too toxic to be widely used in this context. And so at ASH 2014, we did hear 2 randomized trials of maintenance therapy with anti-CD20 antibodies after chemoimmunotherapy, one with rituximab and one with ofatumumab. The rituximab data were at relatively shorter follow-up and I thought not as compelling as the ofatumumab data, where there was an approximate doubling of the progression-free survival. However, it is important to realize that these patients had rituximab-containing chemoimmunotherapy and then went on to ofatumumab, which is essentially like adding a new therapy more than it is maintenance. That being said, there may be a subset of patients who tolerated their chemoimmunotherapy quite well without significant cytopenias or infections, for whom consideration of this option could be a reasonable option based on what we saw of the progression-free survival data. These patients would probably be lower cytogenetic risk or more indolent patients because of the fact that with the advent of the novel BCR inhibitors, we're less likely to use chemoimmunotherapy in a relapse setting in anyone but those lower risk patients. Patients who had significant cytopenias with their chemoimmunotherapy, I would not tend to favor maintenance because there can be an increase in neutropenia in patients with cytopenias. Patients who had significant infectious toxicity, I also would not consider as candidates for maintenance. And so it would have to be patients who made it through the chemoimmunotherapy successfully without any major complications and who didn't mind coming in for intermittent infusions for potential increased duration of benefit from that prior therapy. Many patients, I think, would not be so inclined to do this. They'd rather just be done and take their chances, but there are a subset of patients in whom this could be compelling. Patients who are MRD positive and are interested in that finding may, for example, be interested in trying to see if they could become MRD negative, although as yet we don't know if that is achievable.